All right, so let's get going. So, as I mentioned a few minutes ago, because this is essentially an extra session, and our speaker for the domain that we would have done next week um, was not scheduled to be here, I pulled forward one of the smaller domains, which is domain number 4 on revenue cycle. I pulled that forward for today. Um, this domain seems to be a domain that people struggle with on the RHIA exam, and I think it has something to do with um, how it's presented in academic programs. I think that there is no real world connection to the revenue cycle, and I think that that's why a lot of people struggle. So for today's session, I'm going to um, tell a story about a patient encounter, as well as cover the content that falls under the umbrella of revenue cycle. So the handouts that I sent you, one of them was an actual slide deck, but the other was a patient record that I'm going to use to kind of guide our journey of the patient encounter. So, the one thing I want to remind you of, and I want to keep this in the back of your mind, for this national exam, it was written for individuals that have completed a KHAM approved program. And with KHAM approved programs, there was certain content that was a part of your curriculum. But then when AHIMA gives you your content outline for the exam, the content outline is very brief. And to me, it gives you a false sense of what you need to know. And so you're going to see today that I'm going to cover topics that are revenue cycle management, but are not on that content outline, but are on the curriculum for revenue cycle management. So the first thing that I think is important for you to know is that the revenue cycle management process is, in English, how we go from a patient to payment and all the steps in between. Now, if you talk to someone who's a member of the Healthcare Financial Management Association, they will tell you that the revenue cycle has a front end and a back end. But if you talk to a HIM professional, they will tell you that the revenue cycle has a front end, a middle, and a back end. And so what we're going to do today is walk through that journey from front end to back end and everything that takes place in between to help you understand the concepts that you should know for your exam so that you can do, our 3 buzzwords: recall, analysis, and application. And I know that there are parts of this that you guys are familiar with. And so I'm going to, of course, solicit audience participation because I want to make sure that you are continue to be engaged in this process. Oh, and speaking of engagement, I have a question for you. What did you do this week? And Mohammed, because we are about to enter into September, I'm going to ask you first. What did you do this week?
Uh, I finished up to 15 chapters.
15?
Yes,
Oh my.
yes. And next 2 weeks I will be doing another resta bump, and then after that I will have 2 more weeks, which is I'm completely off, and that 2 weeks will be only question and answers, practicing all the questions from whatever book I have, and the domains you have given, all those I will be practicing. That's my
Okay.
target. Yeah.
And you're going to focus on recall, analysis, and
Yes.
application,
Yes.
not just recall. Okay. Anybody else?
Finished chapter 3, 4, and some of 5.
Okay.
Uh, Same thing. I did the learning objectives again and the questions throughout every few pages that they ask. And
A-
I also, yeah.
And because you're kind of redoing,
Hmm.
are you seeing content in the book that you're like,
Yeah.
man, if I'd have done this first,
Yeah.
yeah. And I'm sorry, I wish somebody would have just really drilled that in your head, like, like really drilled it in your head that that was critical.
Yeah. Yeah. I had no idea. But I think it's like as I read it, I'm like, oh, like it ties everything in. And
Hmm.
because it's like a story, basically.
It is. And the
Yeah.
revenue cycle actually is like a story too. Okay. Someone else. John, what did you do this week?
I read chapter 4.
All right. So you're trucking right along. And I know it's kind of boring, isn't it? Do you find yourself like sleepy when you're reading the chapters?
Yeah, I got to take a lot of breaks.
Yeah, yeah. So I don't know if you, but this is me. That is not a book that you can read sitting in the bed. You got to kind of like be sitting up somewhere away from the bed, kind of maybe need to have some background noise going on to kind of help you make it through, because some of it is very boring. But when you're reading, do you kind of think about the concepts in terms of recall, analysis, and application? Like, do you see the concepts in action? Because maybe that'll help it not be so boring if you think about, well, how does this work in the workplace? Why is this important in the workplace? Because that may help you get over the boring part. Because I know it's boring. It's very boring. Al, what about you?
I made some flashcards with definitions. I try to learn the definitions and try to recall what I learned after.
Hmm. Yeah, because if you don't know the terminology, it's difficult to
Mhm.
answer the questions. Hmm. All right, let me see who else is on here. What happened to Lovey? I saw Lovey a little. Oh, there's Lovey. Lovey, what you do this week?
Well, I finished up chapter 5, and pretty much I spent most of the week just going over like everything that we went over last week, and it made last Saturday, and it made like getting through the chapter a little bit easier, I think, just because I was able to say, okay, I understand that, instead of having to go back and read it a couple times, because we actually discussed it. And I think I took pretty good notes last Saturday, so it made the reading a little bit more easier for me, I think.
Okay. All right. All right. Well, I'm not going to go down the entire list for everybody, so thank you. So, one of the things that I think that the textbooks don't do for revenue cycle is that I don't think that it brings it to life. And so one aspect that the textbooks don't cover is the fact that the revenue cycle process starts at the time that the patient accesses our healthcare services. So at that registration desk, commonly known as patient access. So whether it is the physician office, whether it's the hospital, that patient access department is where our revenue cycle process begins. And when that patient is at that registration department, what is some of the data that we begin to collect? And we talked about this last week, but what's some of that data that we collect?
Insurance information.
So yeah, so we get insurance information, we get demographic information, right? And why do we need demographic information? Why do we need to know their name and where they live and all of that?
To send a bill to them,
We know who to send
the
the.
insurance company.
So we may need to send the bill to them, but also when we are sending the bill to the insurance company,
Yeah.
the information that we have in our system needs to match what the insurance company has in their system. For example, I know a gentleman who works for an organization here in Chicago where his company, the Human Resources Department, entered in his date of birth incorrectly into their system, which then went to the insurance company's system incorrect. So when he went to the doctor's office had the correct information, but when they pushed the claim through to the insurance company said it was wrong. It was right, but it was wrong. And it was wrong because the Human Resources Department had put in the wrong information. So he had to go back to his Human Resources Department to have them correct the information in their system. And then this was Blue Cross Blue Shield of Illinois. They had to correct their system so then the doctor's office can then push that information back through. But meanwhile, the doctor's office told him that he had to pay cash for those services. So why did he have to pay cash for those services?
Because insurance will deny.
Yeah, the insurance did deny because they said that the information doesn't match. And so healthcare is a business, and in order to stay in business, we got to get paid, right? Because what's the biggest expense that our healthcare organizations have?
Payroll.
Payroll, right? So we can't give away free services because we're not going to be able to stay in business. Okay, so at the time of that patient access point, and in some instances, we're collecting some of this information ahead of time via the pre-registration process when the patient calls in. But if you have a situation like an emergency room visit or urgent care, we're collecting this information at the point of service. So we're collecting the demographic information. We also are collecting their insurance information, where the patient is working. We are also getting a copy of the patient's ID. Why do we need a copy of the patient's ID?
To make sure it matches the information the insurance has?
Yes, because back in the day, people would use each other's insurance card. So like, I don't have insurance, but my friend has insurance, so I'm just going to use my friend's insurance card to go to the doctor. But what's the problem with that? And I want you to think data collection.
Wrong health information.
Yeah. So if I use my friend's insurance and I go to the urgent care because I got an itch down there and they treat me for a sexually transmitted disease, well, it's not, if I'm using my friend's insurance, it's her that has the sexually transmitted disease now instead of me because I used her insurance. So now the codes are reported on her instead of on me. So making sure that we have the right patient is important for data collection information. So although this is not on the domain outline that AHIMA gives you, you should know the differences between your different insurance payers, your private insurance companies versus your government payers. So I'm not going to go into detail on these, but when you read your chapter on reimbursement, they get into government, Medicare versus Medicare, TRICARE, CHAMP VA. And then on the private side, that's where you have your commercial payers. So your Blue Cross Blue Shield, your Aetna, your Cigna, your Humana, your United Healthcare, all those different plans. But today, we are seeing that in the government space, a lot of the commercial payers are also involved with the government because, for example, under the Medicare program, specifically Medicare Part C, which is Medicare Advantage, a lot of the commercial payers are offering Medicare Part C products. So just understanding at the point of service, when we're intaking the patients, we have to understand what type of plan the patient has, because that's going to impact if the patient can even be seen. So for example, my mother has Medicare Part C, and she's enrolled in an HMO plan, which means she can't just go to any doctor's office that she wants to because she has a primary care physician. So what does that mean?
That's the physician she assigned to, that they'll pay for her to see.
Yes, and he is the gatekeeper of her services. And anything that she needs outside of the gate, she has to get permission from him to receive those services. So she can't just go wherever she wants to go without getting permission from him. So everything has to go through him, and that's the whole concept of managing the patient's care. That primary care physician is essentially the captain of the ship. Now, that primary care physician basically is assuming the risk for caring for her and is receiving what is known as a capitation payment to be basically for her to be on his list. And the goal is to keep her healthy and that she's not in that office every month receiving healthcare services, so that it lowers the risk associated with caring for her. So one of the things that used to kind of be, I'm not going to say it was a trend, but it was a trend. When HMOs first came out, doctors wanted to get a caseload of all healthy patients, because when you're healthy, how often are you going to the doctor's office?
You're not going very often.
You're not going very often. But if you're on that doctor's list, that they're your primary care physician, they're receiving a monthly payment for you being on their list. And so as long as you don't come, they're winning because they're getting that payment per month, per member, for you showing up. All right. Terminology that you need to be familiar with when your patient is at the point of service for patient access are premium, deductible, co-payment, and co-insurance. So what is the premium?
Is that what you have to pay per month or however you're set up to have the insurance?
Yes. So it's like your car insurance. In order to have car insurance, you got to pay a premium, and your premium could be paid monthly, it could be paid every 6 months, or it could be paid annually. And with car insurance, if you have a car accident, before they repair your car, they make you pay a deductible. Now, what determines how high your deductible is?
Depends
Is
on
it,
what kind of insurance you have, how much premium you pay.
I think
How much premium you pay? What else?
if you pay more, then deductible is less.
Yes. So, for example, my deductible for my car insurance is $250. So that means my premium is higher every month. Why? Because if I have a car accident, I can come up with $250 as opposed to trying to come up with $500 or $1,000 for my deductible. But that means every month I'm paying more. So health insurance, depending on the payer, works the same way. So I'm going to use again myself as an example. So monthly, I'm paying a premium for my health insurance that keeps the insurance going. And then every calendar year, I have a deductible that I have to meet before my United Healthcare will pay. So my deductible is $1,250. And so United does not kick in until I've paid $1,200, $1,250. So until I pay $1,250, they pay nothing. But meanwhile, I'm still paying my premium every month. That's why the health insurance companies are like the richest in the world, because I'm paying, and if I don't get to $1,250 by December, guess what? They don't pay anything, they win. So right now, I think I'm at 500, and it's September. So unless I get really sick, it is likely that I'm not going to meet that $1,250 deductible, but I'm still have to pay my premium. What happens if I don't pay my premium?
You get dropped, right?
They're going to cancel my policy. It's just like car insurance. If you don't pay your premium, you're going to have a lapse in coverage. So sometimes we will have patients that present to us where their employer has not paid their premium, so they don't have insurance. So let's talk about right now during this pandemic. There are some people who have insurance through their employer, but if the employer is not bringing in revenue to pay their premium and they miss a couple of premium payments, do you think the insurance company is going to keep their insurance active? More than likely not. So now you have a patient with a lapse in coverage. Insurance companies like Medicare, or payers like Medicare Part B, patients have a premium that is automatically taken out of their Social Security check. They don't give the patient an option to send in the check. They automatically take it out. And then every year, the Medicare patient has a certain dollar amount that they have to pay before Medicare will pay. And that varies by patients. You can Google what the current dollar amount is. So then what is a co-payment, and how does it compare to co-insurance?
co-payment is upfront payment?
Co-payment is upfront, and it is a small fixed amount.
Yeah.
Now, small is relative because when I go to the emergency room, it's $200. $200 is not a small amount, but that is my co-payment that I pay at the time of service. And a lot of people don't know this, but contractually, our agreement with the insurance companies is that we will collect the co-payment at the time of service, not that we will bill the patient for the co-payment. So for example, think about an office visit where the co-payment is $10. Does it make good business sense to bill the patient $10 for a co-pay?
No,
Why?
it's too much work. It's gonna be so many bills.
Number one, you have to pay for the envelope.
Yes.
Number two, you have to pay for the piece of paper that goes in the envelope. Number three, you have to pay for the ink to print the statement on the piece of paper. Number four, you have to pay for the postage. I don't know what postage is today because I buy the forever stamps, but I think it's about, seems like it's about 50 cents now. I don't know. And then you have to pay somebody to do that work or push the button on the computer, whatever the case may be. So you spend money, spend $5 or $6 trying to collect $10. That doesn't make any sense when our contract says that we will collect that payment at the time of service. So one of the things that we try to do with office visits is that we remind the patients before they come in to please bring their co-payments. And then what a lot of emergency rooms are doing is, like when I went to the emergency room recently, they told me, your co-payment is $200. But if you pay it now, we'll give you a 20% discount and you only have to pay $160. And so I was like, yeah, I'll do it because I wanted that discount of $160. Now, one of the things that I was wondering, and I meant to check with one of my legal friends, I wanted to know if it was acceptable for them to offer that discount. But I haven't checked with one of my legal friends because I really want to know if that's acceptable for them to do that. But I took the discount because I'm all about discounts. All right, so co-payment, small fixed amount due at the time of service. So then what's co-insurance?
Is it something like second insurance? After some certain amount, it goes to the second one?
No, so actually, co-insurance is a percentage that the patient pays after their insurance has paid. So I'm going to use my insurance as an example. I have a PPO, preferred provider option. And so I had surgery, and my surgical procedure, I can't remember what the dollar amount was, but my insurance covered 90%, and I was responsible for 10%. And so that was my co-insurance. So if you can visualize this, co-payment is a small fixed amount, whereas co-insurance is a percentage.
Okay.
Make sense? And I'll tell you something else that's interesting. When I had my surgical procedure, when I was in the pre-op testing area, when I went to have those services, they told me, they gave me a piece of paper and they said, your insurance company covers this dollar amount. This is how much you will owe. How will you be making this payment today? They expected me to make that payment right then and there before I had my surgery. So I said to them, I'll give you some of it. I'm not going to give you all of it, because what if my surgery gets canceled? And then, I got to chase after you for my money. So I gave them a portion of it. And then they said, okay, then we will expect the rest of it on the day of surgery. How will you pay? I said, oh, I'll pay Visa. So when I arrived on my day of surgery, they said, we'll take your Visa payment now. And I know you may be thinking that sounds kind of harsh, but it was an elective surgery. And this is healthcare is a business. And it's better to collect the money up front than afterwards. Because after I got my surgery done, then what's my incentive to pay the money? And it's harder to chase the patient down afterwards than it is on the front end. All right, so we're still talking about patient access. So we have the patient fill out the registration form. We understand the specifics about getting a copy of the ID card. We understand the different terminology. We must get a copy of their insurance card. And as it relates to the copy of the insurance card, what do we need to copy?
We have to make sure we get the member ID number.
Yes, but we want to get a copy of the front
And the back.
and the back.
Where
The front and the back, because the back of the insurance card is where you're going to have telephone numbers, where the bills go to, and all of that. So we always want to get a copy of the front and the back of the card. Now, just because the patient gives us an insurance card, does that mean that their insurance is active?
No.
No, that's correct. Because when you lose your insurance, you don't get a card in the mail that you carry around that says you no longer have insurance, right? So how do we find out that the patient no longer has insurance?
Once we either call, or in my job, we use a software that verifies insurances.
Do you use can you swipe the card, the barcode?
No, we have to go in and type like the patient's information, the member ID number, and then it comes back.
Okay. All right. So since you work in patient access, is there anything else that you do? Oh, wait, I have two more things. We want to make sure we give so on the front of the card, you may or may not have information about the patient's co-payment, co-insurance, all of that. I noticed on my insurance card, it's interesting. Some years it's on the front and some years it's not on the front. So because I need to know for myself, I always, log into the system and see what my cost sharing requirements are. Because I don't like to get to the doctor's office and they tell me that it's $1 amount and I know it's something different. So I will always go in and print the little paper and keep it in my purse. So if they try to tell me something different, I say, nope, this is what my insurance company said, so that I can pay. So the other thing that's important about this process is making sure that we confirm that the information that's in the system is correct. How do we confirm that the patient's demographic information is still correct? Do we say, has anything changed?
We give forms they have to fill out.
So we either give them forms that they have to fill out, or do you still live at the address on 12345? Like, we might not say the city and state, but do you still live at 12345 State Street? Because if you say, has anything changed, and I can't see what's in the system, how do I know what you're talking about, right? So some places will give the patient a printout, have them look it over, cross off if anything has changed. So we want to verify that our patient's information is the same, because again, if we need to send them a bill, we need to make sure that we're sending the bill to the correct information or to the correct place. Other forms that we're giving the patient during patient access, notice of privacy practice. What's the purpose of this notification?
Letting him know the information is confidential.
Anything else?
Yeah. By law, HIPAA states that the patient has to be informed of how their data can be used.
Yeah.
Yes. So how their data is used. And basically, we're telling them that we're going to use it for treatment, payment, and operations, TPO. And then we're also letting the patient know that they can get an accounting of how we disclose their information, which is something under HIPAA as well. All right, so the other forms that we're going to give the patient is a consent for treatment. We also are going to give patients, and this is something that I hate. I hate when the patient access person tells me, sign here, this is just for us to treat you. Well, this is not just for us to treat you. This is for us to treat you. This is us saying that we can disclose your medical record. This is us saying that you agree that the payment can come to us. So you are assigning your benefits from your insurance company to us. And you're also saying that for any reason, if your insurance company does not pay, that you will pay. So it's not just to treat you, it's more than that. And most patients don't even read it over. They just sign there and they move on with life because we say, this is just for us to treat you, when it's actually not just for us to treat you. All right, Dee Dee, do you have any other things that happen during patient access that you want to share with the group, since this is where you work?
Yeah, so we do a lot of with patients with Medicare. And one constant thing that happens when they come in is that their name is never the same, like on the insurance card and their ID. So when we go to run like insurance, it could be that the middle name is missing on the Medicare, so it comes out like unknown. But then we look into the ID and it's because they have a middle name, a middle initial. So we have to make sure that the information is constant. It's either we go off what's on the Medicare card. So if the name is different on the Medicare card than on the ID, we go off the Medicare card. And we still take the ID just to make sure we have the demographic correct. But that's one thing that we always try to do. It's also hard because patients move and they forget to tell us, or they don't remember, or they don't want bills, So they give us, a lot of patients give us like a fake address, our old address, their mom's address. And so it's like a constant battle with that because they're not always honest. But those are things I see. Insurance wise, we run the insurance, like if a patient comes in once a month, we run it for that month. But if they come in every other month, we run it again because sometimes the coverage changes and they have no idea. And they're like, no, I'm active. I mean, it's the same member ID number, and then it's not. So that's
Can't take it for granted. So those are actually some very key. First of all, I think every time you show up, we need to verify insurance because things can change. When I went to the hospital recently, the patient access representative told me, your insurance isn't active. I'm like, yes, it is. I said, I gave you my insurance card. Did you confirm that what you have in the system is what's on my card? And she said no. And I'm thinking to myself, Oh, shame on you. This is what you're supposed to be doing. So after she plugged in my information into the system and ran it through, then she realized that I did have insurance. So why I had to tell her to do that, I don't know. But I also told her, if your department needs training in this area, let me know. Here's my card. You know, I was just going to get a chest x-ray, but I'm always available to train some people, because why should the patient have to tell the person that's registering to make sure that the information is current? I'm not supposed to be telling them how to do their job. And then the other thing that you mentioned was about patients giving bogus information. That is why you need to collect the payment up front. And a lot of organizations, they struggle with that because we don't want to seem like we're money hungry, but some organizations can't even barely pay their light bill. So it's not personal, it's business. And if you think about it, if you go to work every day, at the end of the 2 weeks, you expect to be paid, right? So if we have hospital employees, physician office employees that are coming to work every day, that are providing services, that are keeping the facilities clean, that are providing the services to the patients, we have to get paid for the services that we're rendering. Dee Dee, you were going to say something else?
I was going to say, because I work, you know, I collect the money as well. One of the famous lines we hear a lot is, well, we can't verify their deductibles. Like, we can see if they pay copay or not, but we don't know if they hit their deductible mark. I hear a lot, well, I already met my deductible, so I don't have a copay. But they're lying.
Mm-hmm.
A lot of times it comes back and no, they didn't meet it. They actually have a copay. And my job, they charge a late fee for every bill they don't pay after 30 days. So it gets, it gets expensive for them, and it gets frustrating for us because we have to hunt them. But,
do you have them sign a financial agreement?
Yeah.
Yeah. And again, they probably don't read it.
Mm-mm.
And that's why they give bogus information. I remember dealing with a patient who we didn't collect the money up front. And he was in a very rich area of Chicago, area called the Gold Coast. And we didn't collect the money up front. And so we were trying to collect it on the back end when he was finished with the doctor. It was a podiatrist. And he said, "Oh, I left my wallet in the car. I'll be back." And you know he didn't come back. All right. So after all of this patient access process, that's the beginning of the revenue cycle. The next part is what we call the patient encounter. And that's where the patient is actually going to see the provider. So that takes us to the handout that the patient case handout that I emailed you, which I'm actually going to pull up on the screen. So give me 1 second. And anybody else want to add anything to the patient access